Good evening, everyone. I'd like to call to order the Macomb Community Mental Health Full Board meeting for December 17th, 2025. Please rise for the pledge.
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Next will be the reading of the mission statement from the birthday boy.
You don't have to tell her. Okay. Our mission, Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you, Nick. Next item is adoption of the agenda. I'll take a motion to adopt.
Support.
Motion from Lori, support from Donna. Comments, questions, changes to the agenda? Hearing and seeing none, all in favor say aye.
Aye.
Aye. All opposed? Agenda is adopted. Next item is hearing of the public. Anybody from the public wishing to speak on any item on today's agenda has 5 minutes if they wish. Anybody from the public wishing to speak? Okay, seeing none, we'll close the first hearing of the public. There is one more before the end of the meeting. And we will move on to item 5, which is the minutes. I will take a motion to approve the CMH full board meeting minutes from November 25th, 2025.
So move.
Motion from Wayne, support from Donna. Comments, changes to the minutes? Hearing and seeing none, all in favor say aye.
Aye.
Aye. All opposed? Minutes are adopted. Item 6, approval of standing committee meeting minutes. We did not have program and budget this month, so we will skip that one and move on to item 7, request to approve. We'll start with item A. I'll take a motion to approve the contract with Tracy Smith as MCCMH's CEO beginning January 1st, 2026.
So moved.
Support.
Motion from Nick, support from Antoinette. Just a quick note, you all saw this last month. There were a few minor technical continuity edits and changes that were made, nothing substantial. Still at 2 years, which is great. The exec's office has agreed. Tracy has agreed. HR has agreed. Now it's up to us to agree, or not, but we should. Are there any comments or questions on the contract? Okay, hearing and seeing none, all in favor say aye.
Aye.
Aye. All opposed? Motion passes. Congratulations, Tracy. We're happy today. Next, I will move on to item B. I'll take a motion to approve an engagement letter from Roseland Prestige and Company in the amount of $25,000 for the fiscal year 25 compliance audit. Motion from Donna, support from Lori. Tony, go ahead.
Yep, thank you. So this is our annual compliance audit. It's a requirement. We have used the same firm since 2019. They have not increased the fees. We haven't had any issues with them, so we recommend moving forward and having them do our compliance audit.
Thanks, Tony. Any questions? Okay, seeing none, all in favor say aye.
Aye.
Aye. All opposed? Motion passes. Next is item C. We'll take a motion to approve, motion for approval to, oh my gosh, let's start over. Scratch that. Motion to approve the contract for occupational, speech, and physical therapy. Motion from Antoinette, support from Sharita. Okay. Tony, go ahead.
Yeah, on behalf of Christina, I'm going to represent these two providers that we're bringing forward. We went through an RFP process looking to expand our OT, PT, speech network. We followed our normal process. These were the ones that were highest scoring and recommended to bring forward. So a couple things with 3 points. The providers are currently contracted. They provide ABA services, so they're not new to our system. I understand the contracts are in good standing and there are no current compliance or ORR issues with either one of the vendors. So we're bringing them forward to begin contracting with them.
Thank you, Tony. Any comments or questions? Okay, seeing none, all in favor say aye.
Aye.
Aye. All opposed? Motion passes. Thanks, Tony. Next is item 8, receive and file, no items there. Item 9, resolutions, no items there. Item 10, I will take a motion to pay the bills.
Support to pay the bill.
Motion from Antoinette, support from Lori. Comments, questions on the bills to be paid? Seeing none, all in favor say aye.
Aye.
Aye. All opposed? Motion passes. Bills are paid. And now we'll go to the CFO update. Ken and Tony, just Ken.
All right. Going to deliver the board report. This will be Tony's last board report with us. So moving on to a different role. So congratulate him on that and look forward to your future success, Tony. So we'll roll through this as we usually do. The first page, sorry, I don't have it numbered, but the revenue and eligibles page. As we can see here, both the revenue and eligibles are obviously tied together. They're trending down. They continue to trend down. Explanations for that are limited, and we're somewhat at the mercy of the eligibility from the state. So we look at this, we track it, it impacts our revenue. We have a little bit more control over SED, children's waiver, and HAB support waivers. We specifically enroll those, and there's tracking related to that. For others out in the community that don't touch our services, we can only do so much. Spread the information, work with other departments, and getting people enrolled in Medicaid is good, not only for us, but for them, and they can get their medical services and everything as well. I'm going to skip the next couple charts as far as the graphs go. I don't know that there's anything particular in there that I want to cover. I will go to the revenue and expenses by funding source. We usually try to spend a decent amount of our time. I'll preface this by saying this is our kind of our preliminary look at what year end is going to look like. We submitted an interim FSR November 10th, that largely mirrors this as expected, but as the group knows, January and February are reporting season for us. It's audit season for us, so we'll have final numbers, I'm guessing, in the March meeting, once we usually go right up to the deadline, but do issue on time the last several years. So expect to do so again, but I just wanted to say that about these numbers and where things stand. The first two boxes are Medicaid and Healthy Michigan, as we normally talk about. If you add the surplus there's about a $37 million surplus there. That represents what we expect our labs back to the state of Michigan to be. I know that seems like a big number. We've done a couple things that when we push dollars back into the fiscal year, which we did with inpatient and CLS, to offer some stability to those service lines. We have to do so with the idea that that's sustainable going into next year. So we've increased those rates, pushed it back into last year, and kept it going into next year. Otherwise, it's kind of a spend down of the labs, and then not only is that unallowable, but it creates a kind of a weird precedent going forward. So we want to make sure that's sustainable. I will remind the group that the pendulum has swung the other way in 26. We're expecting to pull money out of our ISF because this $37 million lapse is probably going to be a $15 million deficit. So spending this down and increasing rates and things like that would not be a prudent move in 25. So I wanted to provide some context around that because I know that that's something that we're looking at as a group. But that's what's going on with that piece. I'll also direct your attention down to the risk reserve.
You can see there at the bottom of this page, there's about a little over $60 million sitting there. That is actually above what our ISF actuary report says. The reason being is that we earn interest on the funds that are in our ISF. We largely have fixed income securities. As a government entity, we can only invest in so many things. And our interest, our investments have done well across the board. So that amount brought us over, I think 58.9 would be our ISF actuary number. So we're a little bit over that, and that would be even setting our dispute to the side of how this should be calculated. We will have to spend that down or abate it in 26. That's something that would have to happen either way. So I just wanted to call your attention to that as we look at the ISF and where we stand there. Going to the next page, CCBHC non-Medicaid. We did finally get our allotment from the state. It was about $482,000, which is more than last year. Still a far cry from $4.7 million. That's our actual expense. This year, as we've talked about before, if we kind of go down to the bottom in the all other box, you can see we have a negative $4.8 million there. That's our loss in the CCBHC program. Our loss is largely driven by the removal of 3 CCBHCs in our county, which were lower cost services and high volume. So we effectively get the high cost services we provide for the high needs individuals and that kind of thing in our county. So we continue to advocate with the state about, we submitted a CCBHC cost report based on these assumptions, and then the rules were changed on us. Can we revise it? There's discussion right now. The state is waiting for CMS approval for anticipated costs in the 2025 report that's coming up, so that we can try to capture some increased costs as it pertains to the CCBHC direct pay, and a couple of other items potentially depending on what we have to try to properly reflect the cost for a program. So you can see though, at the end of the day, if we go back to that all other box, we're still expected to put about $13 million in fund balance. There's a couple things driving that. One is the interest that we've earned. They've changed the way they've calculated the CCBHC quality payment to our benefit, which is nice. So the state heard the feedback from the field on that. So it's not as rigid as it once was. So we've got about $2.5 million that was awarded there. Our PBIP, which is another quality item, is about $2 million. So you add those things up, we're in that $13 million bucket. So overall, 25, I think is going to end in a strong position, but we do have some risk going into 26 that we're looking to address. So the subsequent pages are the detailed financials. I don't have anything in particular to cover on these pages, but happy to take questions if anybody has any. I do have some narrative items, as I usually do, but if there's anything on the packet in particular, I'm happy to field questions. Tony, anything else to?
No, just a correction, we said CLS is where we pushed some rates in this year, but it was really specialized residential.
Oh, I'm sorry. Yep.
Just so for the record, and all of our providers will be happy to remember that.
I did mix that up. Last year was when we did the CLS, so I appreciate that, Tony.
Not seeing any Donna, go ahead.
I'm just wondering, do we know if the CCBHC cost is going to just keep on increasing, or do we have any indication at all for the third party, the CCBHCs, that it's going to just keep on getting higher and higher, or do we have any idea about that?
So our CCBHC cost is largely tied to our direct run operation. And we have a number of DCOs in our network. So they kind of function like direct run providers in this model. So we continue to increase rates for our DCO providers because they have increased costs, they're largely inflationary things, but we have a number of costs that go up as well. So when you just look at anything from supplies, you know, we have salary increases to take care of our folks, and there's just generally higher costs for everything. So when our costs continue to go up, the real problem then becomes that we're spreading that cost over less eligible days. So the way that we generate revenue based on the eligible days. So when you have less, it's really more of a revenue side of the equation problem than an expense, because the state and the feds do allow for an inflationary increase in the CCBHC daily rate. So we're kind of lockstep there. It's just that, like I said, we've pulled, I want to say 30,000 days out, and that 30,000 days worth of costs is less for the DCOs than it is for us. Does that make sense? Like that transition? So our costs are the same, we just can spread it over less days, so we're losing money on the revenue side. We're gonna wait and see. I'll keep the group updated. Right now, we're working on the cost report. The state just gave us the templates for this year. So we're filling in that information, and like I said, they're still waiting on some approvals from CMS, so we have not heard about that. So, yep.
Nick?
I think I heard you say something about the acuity level of the cases that the four CCBHCs in the county are taking. I thought CCBHC by definition was a take-all-comers system.
It is, and I probably made a generic statement. I mean, I think we all see people that have high needs. We generally speaking, have a higher proportion of them in our services, right? So we have a lot of the walk-in hours, and as by our own definition here, kind of the safety net for the community. So
Yeah.
we have a lot of those high
I
needs
guess
folks.
what I'm asking is, are we seeing the other CCBHCs skimming or denying and sending people that are higher acuity to us, or are all for doing what they're supposed to do, which is take all comers, or are they providing less services than we provide, or both?
I don't have any data available to say that that's what they're doing. I just think that even when the CCBHC model kind of transitioned, again, by our nature, we had some of those folks already in programming that had very high needs, so we moved them into that program.
Oh, okay, so we just have a higher percentage of high need.
Yeah, and it's also, you know, if you think about it this way, if you have someone with high needs, so you provide, maybe it's 2 hours of therapy, this could be a bad example, but, and another person who has less needs is only an hour, you've got the cost for 2 hours here, but we still get paid the same daily rate, regardless of whether it's 5 minutes or 2 hours. So there's a certain balance there when you have more minutes attributable to a particular person. So I hope that helps.
I guess I lost you. I thought this was a fee for service.
It is in a lot of ways. We get paid, it's not a fee for service arrangement, so we get paid one rate per day. So if we provide service in a day, we get the same payment, the PPS 1 day payment, whether we provide 5 minutes of service to that individual or 2 hours, and anything in between. So when we have a higher acuity person, they tend to have more time, you know, so you've got the cost. But it's supposed to average out over the total population, right? So some people are higher, some people are lower. In the end, your program's supposed to be sustainable.
Just as a generality too, anything that I'm about to say, I'm not presenting in a negative fashion. That is not my intent. Our staff cost is a little bit higher not necessarily because the staff make more, but we do have higher benefit costs, pensions, things like that in comparison. So there's that small difference. In addition, to be fair, we have been the safety net for decades. Therefore, everyone knows you come to us, right? And we have longstanding individuals who have been with us for over 40 years with very high needs, right? So the CCBHCs, good organizations doing good things, but they've only been that component of it. And just to keep in mind, the CCBHCs do not provide all services. They provide just CCBHC services, which most are case management are not necessarily as intensive as some of the other ones that we do. So I guess people often come to the organization that can give you everything, up including to the intensity level. So they tend to come to us because of who we are and because we've been around for decades being that safety net solution. So I just want to kind of quantify it a little bit that we have a certain demographic for multitudes of reasons and we have cost for multitudes of reasons.
Yeah, Tracy, I'm not, I expect us to be the safety net. So that doesn't concern me, and I think we should be offering that service. The only thing I was concerned about is if the other CCBHCs were essentially cherry picking and sending folks over that they didn't want to deal with, because we've seen that happen in private versus public services in other areas, and that's not the intent of this program. I just wanted to make sure that wasn't happening, and I think what I'm hearing is that's
Yeah, we
not.
don't have data, nor would I imply, right, that is occurring. I think the design has caused all of us, because there is almost an incentive, and I'm always a big fan of just being really, really honest and direct. For all of you who know, there have been discussions, and there have been some, I'm not saying here in Macomb, but some that have been challenged in the manner in which they're approaching it. So I do think, to be fair to those organizations, the way the system is designed, it has the potential to cause some to maybe do that type of activity. So the state ultimately just needs to monitor that to ensure it doesn't occur.
Thank you.
Thanks, Nick. Are there any other questions before Ken rolls into the narrative piece? Nope. Okay, go ahead.
Okay. Happy to report that the ACFR was issued. As a result, we submitted our compliance exam, our medical loss ratio, and the related tie-out for that. I think those are the only two things that were due, but we submitted those before Thanksgiving, which we had extensions for from the state. Switching gears, now we're in the next audit and reporting season, as I mentioned. So we've got the next one upon us. So the finance team will be heavy into that. And like I said, we'll bring those results. I alluded to it a little bit earlier when we presented the budget. I just want to keep this group updated. When we presented the budget, we had talked about a $13 million ISF deficit. That was based on what the state had in their rate certs. We have some data now in the first couple months of the fiscal year, so we don't get our big Medicaid payment until the end of the month, so December is still a question mark. But I'm expecting even a $5 to $6 million deficit on top of, based on the revenue not coming in at what we thought the state was going to have. So we'll continue to monitor that. When we come in January, we'll have November financials, so that'll give us not only the revenue piece, but we'll have fully costed expenses and that kind of stuff for the group. But just wanted to keep that on everyone's radar as we continue to monitor that. And nothing new on the ISF that I'm aware of. So those were my things.
Thank you. Any questions? Okay.
All right. Thank you.
Tony, thank you for everything. We appreciate you. We're going to miss you. Unless you're sticking around. You're just like shifting departments or something. Macomb County Finance Department is hiring. With that, we'll go to Tracy with the CEO update.
So maybe I can start there. For all of you who don't know, is Tony is leaving to a local organization. It's not our competitor or anything like that, because then we would all be bitter and disparaging. Not truly. But I did want to take a minute to, in case all of you don't, is to publicly thank Tony. Tony has done an amazing job over the last 3 years and some change. He has been such an asset to bringing structure, organization, along with Ken and the rest of the team. But one of the most top attributes that I've always greatly appreciated, Tony, is your calmness and your delivery to deliver very complex information in a simple manner while still being calm, even though it feels like the world's on fire. So I appreciate all that you've done, and so has everybody else in our organization. You'll be greatly missed. Don't forget about us when you're doing amazing things other places. Related to that, when the I can never pronounce that, when the report audit is done, Phil and I were surprised why nobody didn't clap. Because that's amazing. How many times have you heard me? The board report actually got shorter. So if you look at the board report that you should have received earlier today, I apologize, it was closer to the end of the day. It was shorter. That was one of the reasons. But I will go through some quick updates. Going back to your board education, as we try to do that every full board meeting, just a reminder, your last board education had the family support subsidy, and I accidentally forgot to bring these. So these are in front of you. I do have a stack too. So for some of you who want to bring some with you or want to take them, please see me after. But today's focus is on our accessing services kind of brochure, AKA we also call them rack cards. The reason I want to take a minute just to highlight this, and again, just of course it's electronically in your board report, so you can see it there and you can also share it there. If someone tried to simplify the very complex and multi-layered services that we have available, this is it, right? So the concept is if you wanted to access services, it's just like anything else. It goes from like I'm in an emergency or comparing us to the physical health world, I need to go to the ER. And it talks about calling 988, right? I'm in a crisis. It then kind of goes through the next continuum of care, talking about maybe I don't need 911 or 988. Maybe I need urgent care, right? So we have our access and referral or our urgent care facilities, and it talks about those, and it gives addresses, phone numbers, contact information, and then it just goes into like general services. So we like these because, again, people, when it comes to mental health and substance use, everybody goes, well, I know somebody who needs the help, right? But then everybody then just kind of goes, but I don't know what to tell them or where to send them or anything like that. So I just want to take a couple minutes as a friendly reminder. It's no different than physical health. Your reaction to that situation should be, well, are they in crisis? Right? Well, here's the number for crisis. Are they not in crisis? Oh, they need urgent care. Here's the phone number and address, location, or whatever that they can get those urgent care services. And if not, here's our customer service line, right? If you just need to find out information, it's not emergent of any sort, you always have that as available. So this is our simplest, basic, very high level continuum of care information. And of course, if you guys want any additional explanations, I'm happy to do that. I also have multiple copies, so if anybody wants to take them from me, you are welcome to do that. Some other quick updates in the board report. It does mention there was a shared, actually it's today, WASCL non-binding guidance. So I'm just mentioning that because the WASCL member settlement is kind of stumbling out there. I'm not really sure, we're not sure what to do with that because it just says it's a non-binding guidance. So we're sharing it. So when you have it in your board report, if you think it's helpful to review it. And then you'll notice the board report is shorter. It's shorter because there's some other things that I'm sure that are preoccupying lots of entities. And it's the holidays, but we actually have not been as inundated with multiple changes over the last couple weeks. So that has been actually very helpful for us to allow us to actually do some other things and focus on that instead of constantly trying to figure out what the next evolution of something is, an interpretation of something. So therefore, your report you benefit from because it then gets shorter due to the reduced number of monumental changes flying at us. Oh, and I just want to mention, you will see before you, I'm not sure when, they said January, so maybe it'll be February for you, just depends on when it gets sent. PHP Agreement Amendment number 3. The only real changes they've outlined, of course, Drew and I will still review it to make sure we didn't miss any of this, but they're reporting it's going to be kind of the rate documents that Ken was talking about. Macomb and one other region were largely cut in comparison. Most of the regions received increases. So We will continue to try to understand those. Ken did a great job of asking some questions. I don't think he ever received a response, but we will continue to ask questions as we always do. And I'm happy to answer any questions or talk about anything else that you need an information on, but that is all I have for this evening.
Thanks, Tracy. Any questions for Tracy? Okay. Seeing none, we'll move on to other agenda items, reminders. We have recipient rights tomorrow morning at 8 a.m. in our admin building. Program and budget will be Wednesday, January 14th at 6 p.m. here. And full board for January will be on the 28th at 6 p.m. here. Sandy and I are going to work on the calendar for the rest of the year tomorrow, and we will get that out to you. It's not going to be the second and fourth Wednesdays, basically. But we'll bring it, or I will bring it to full board in January, program budget in January. But we will be working on that tomorrow. Other than that, are there any board members that wish to add anything else? Okay, we'll move on to item 13, provider comments. Any providers in the audience wishing to address the board? Okay, we'll move on to hearing of the public. Anybody from the public? You have 5 minutes, sir.
I won't need that much, but
5 minutes?
first of all, I want to thank you for the kind words, and of course, I appreciate the opportunity I've had to work alongside everyone at the office and with this board. You guys are incredible advocates for the people that you serve, so be proud of the work that you're doing here, and it's been a privilege for me to get to know all of you and to see the work that you do and the commitment that you make. So just thank you for the opportunity. I will remember and probably come visit once in a while. I won't bring gifts since we can't do that, but no. So just thank you again, and I want to thank Ken because he's been such a support from day one, and incredible asset as well to this organization. So thank you again, and I wish everybody a great holiday season.
Thank you, Tony. Anybody else from the public wishing to speak? Okay, with that, we'll close the hearing of the public and we will move on to closed session. I need a motion to discuss attorney-client privilege memo dated 12/17/25 pursuant to MCL 15.268(1)H. Motion from Donna, support from Antoinette. I have to do a roll call vote. Jackie? Yes or no? I like that answer, though. Donna? Lori? Phil, yes. Antoinette? Sharita? Julia? Nick?
Yes.
Wayne?
Yes.
All right, we will now be going into closed session.